Good morning. I'm Muriel Bowser. I'm the mayor of Washington, D.C., and we are here today at the D.C. Armory to provide a briefing on the district's response to COVID-19. This is somewhat of a modified mayor-council breakfast in that there's no breakfast, and all of the council members aren't here in person because we wanted to limit, of course, movements in our city. But the council members are joining by televideo. I guess that's what we'll call it. And they're on screens to my left. We are joined by the council chairman, Phil Mendelson, and the Ward 7 council member and chairman of the council's health committee, Vince Gray. So I want to thank them for being with us today. I'm also joined by members of my team. At the dais is Christopher Rodriguez, who is the director of DCHCMA, our Homeland and Emergency Management Agency. Also to my left is Dr. LaQuandra Nesbitt, who is the director of DC Health, who's the district's doctor, and Christopher Geldhart, who is the leader of DC.DPW, but also serves in a leadership capacity in our operations section at Homeland Security for the emergency response. I also want to thank General Walker for his hospitality and having us here at the Armory today, and certainly for the support of the DC National Guard. In general, I wanted to turn to you and ask you for any welcoming.
Well, ma'am, welcome to the historic District of Columbia National Guard. Ma'am, you have our full support. We are with you. We're partners. We will not be late to need. And that's all I wanted to say. You can count on the District of Columbia National Guard.
Thank you. Thank you, General. So let's start. We have a few slides, and then I'll turn to the council chairman for remarks and for questions from the members of the council. So we want to give you what we're calling kind of a situational update to let you know where we are in the district's response to COVID-19. And you probably remember that it was on March the 7th that we announced the very first COVID-19 case. And over the course of the next week, we adjusted our mass gatherings advisory until March 26th. We went to gatherings of no more than 50 people and eventually to gatherings of no more than 10. On March 16th, we also made our bars and restaurants takeout only. So we prohibited dining in all DC restaurants. And on March 24th, we closed all non-essential businesses. And then this week on Monday, along with Maryland and Virginia, we issued a stay-at-home order. So before you, what you see is a chart of various district interventions up till now. And as you know, my first mayor's order we issued in February, and it charged DC Health and DC Homeland Security with coordinating the district's response to COVID-19. And since Friday, March the 16th, both our Emergency Operations Center and our Joint Information Center have been activated at the DC Health Building. And the slide before you just demonstrates the organization of our Emergency Operations Center and also how the daily operations of the government interact with the EOC. This citywide effort, we have been very grateful to have the support of the council every step of the way. The council worked quickly to pass emergency legislation to support residents and local business. The Office of the Deputy Mayor for Planning and Economic Development worked quickly to establish the DC Small Business Recovery Micro Grant Program. In over a week and a half, we received 7,600 applications from local small businesses and nonprofits. And just what you see before you is just an example of a few of the provisions included in the emergency response legislation that included unemployment insurance provisions, public benefits, protections for residents, support for local businesses, and continuity of operations provisions. We know, of course, that COVID-19 has no borders or boundaries, so we are staying in constant communication with Maryland and Virginia and monitoring cases and actions taken across the entire region. We have reported out to you on a number of occasions and shared with you some of those calls. And we have a very clear message when we talk nationally that the nation's capital region is what should drive the discussion around our interaction with the federal government and the things that we need. So we have provided you an update not only of what our cases look like in Washington, D.C., but what they look like in the entire region. And those numbers are on slide 6. This morning, we announced 104 new cases in the district, bringing our total to 757. We also sadly announced 3 additional deaths. This week, we also started sharing ward-by-ward information on positive cases. And you can see before you a ward breakdown and the age groups of the people impacted by COVID-19. Dr. Nesbitt and her team, of course, have examined this data, and they do not see anything remarkable about the ward representations there. And as we said, we asked that no, we can't draw any particular conclusions. It is a reminder to us all that everyone, no matter where you live, need to take heed to the warnings and stay at home. We've we've also ramped up our testing. And in just 10 days, testing has increased from about 300 tests per 1 million people on March 18th to about 4,000 tests per 1 million people just 10 days later. And today is the first day of operations at the UMC drive-through testing site. Our priority, as I stated, with resources like personal protective equipment remains, procuring it and getting it out to first responders and medical professionals who need it. We have shared on slide 9 a sample of what we are procuring, the total ordered, the total received, what's been out, what's on hand, and how much we think we are using of those materials and the rate at which we're using it. So now I want to share some data on the latest. What we want to talk about now is medical surge, and the latest data we have about what we might experience in the coming days and coming weeks. So what we're going to share is based on modeling, and there are various models out there, certainly. And I know everybody has been following what we hear from the White House in various states about what models suggest. So there are multiple models that cities, states, and the White House are looking at. And our model one model that people might be familiar with from the internet and national news is the IHME model. Our concern is that this model may overestimate the impact of social distancing, thus underestimating infections. We are using a different model. The CHIME model, or CHIME model, which makes projections based on total infections and assumes a certain level of random mixing of infected people. What is important to remember is that the models just help us plan for the future, but we are constantly assessing what is actually happening. So using the CHIME model, we expect that over the course of this public health emergency, and this is a tough number to have to report, but we think that we rather be on the side of underestimating the impacts of social distancing than presenting too rosy a picture. We model that approximately 93,000 people in our city could get infected with COVID-19. And I want to be clear that this number is cumulative and does not mean that on any specific day that 93,000 residents have COVID-19 at the same time. So this number represents those people who have been affected and recovered as well. So in this graph, the 93,000 represents all of the people who fall under the curve. Of course, we expect that most of these 93,000 people will be infected with the virus and then recover. Sadly, though, we know, and we see our fellow Americans in states around the country, we know that there will be many people who don't survive. And again, based on the CHIME model, we expect that we could experience a range of loss of life in our city. The mild estimate is that 220 people would succumb to the disease. A moderate would be 440, and the severe estimate would be more than 1,000 people. So as we look at these numbers, I cannot emphasize enough the importance of everyone staying at home. We know that it flattens the curve and it will save lives. Our collective goal, of course, is to mitigate the spread of the virus and save as many lives as possible. And like I said, what these models help us do is plan for the future. And one of the key differences between the CHIME model and the IHME model is the projections for resources needed. So we want to be as prepared as possible. So again, we are using CHIME. And this has us reaching our peak cases and hospitalizations somewhere around the end of June and the beginning of July. So we have talked a lot over the past few weeks about the need to flatten the curve. And so this slide shows how we expect that curve to play out. This prediction is based on a 6-day doubling rate. You can see at our peak, the demand for hospital beds will be greater than our current supply. At our peak, we will need 3,000 acute care beds and about 2,800 ICU beds. This is our current supply. So we're working with our healthcare providers to create additional bed space. And our healthcare providers have been answering the call. On Wednesday, I sent a letter to our hospitals and they responded immediately. This, of course, has been after several weeks of planning and meeting with our Department of Health professionals and our Homeland Security professionals about how each system will plan to meet the surge demand. We confirmed with them that we need to increase our capacity to 125% of our current beds, and we already have identified over 3/4 of that needed capacity. And I want to thank our healthcare providers and everyone who works for them for stepping up to the challenge. We expect that at our peak, our city and healthcare system will need 5,500 beds. And here's how we're going to get there. Number one, we're going to increase hospital space by postponing elective procedures, and that's already happened. Number two, we're going to maximize existing hospital space, expand capacity in existing healthcare facilities by using other available space and adding beds. Number three, by reopening facilities, open furloughed healthcare facilities. We are working with the U.S. Army Corps of Engineers to do exactly that. Number 4, by adding new beds. This means establish alternate care sites outside of hospitals. And number 5, adding staff by coordinating with the D.C. National Guard and FEMA for necessary workforce. Of course, more hospitalizations and more beds means a need for more supplies. We continue to work all of our supply chains to get the supplies our hospitals and healthcare providers need. What we know is to support the added 5,000 beds, we will need to procure an additional 1,000 ventilators, 600,000 N95 masks, 5.6 million surgical masks, 1.4 million gowns, 350,000 face shields, and 40 million gloves. So when we look at those numbers, it bears repeating that everybody needs to stay home because we can drive down the number of infections, hospitalizations, and demand for very, very precious PPE. So we will continue through all of our media channels with all of the leaders in our communities, emphasizing social distancing, only leaving home for essential activities. And as time goes on, this will, of course, be more challenging. For me and all of us, we are affected by this in all different kinds of ways. In my own personal circumstances, me and my daughter and my senior parents, that I am making sure that we have a safe plan for. But if you are at home and feeling ill, we want you to remember the symptoms of COVID-19, to contact your medical professionals, and to strictly follow their advice. If you're feeling ill, stay home. Isolate yourself. And I want to end by saying that with all that is going on, there have been so many people who are stepping up in our communities. I want to thank all the frontline workers who are out there in all of our essential businesses, but especially our grocery stores and the people who are providing essential supplies to the residents of the District of Columbia. I want to thank all of our government workers who are working at home in some cases, but in other cases, their essential work involves them going to a workplace. So I want to thank them for everything that they are doing, from our DPW workers to the folks in our unemployment office, to our first responders at FEMS, at MPD, to the folks at our correctional facility, the people who are working in our shelters, even people that you may not think about who are crunching data and putting out all of the materials that we are presenting to you each and every day. I want to say thank you. I also want to say thank you to folks who are doing acts of kindness outside of their normal work, like Jose Andres, who called me early on saying that he was devising a plan to make sure that World Central Kitchen can keep feeding people in Washington, D.C. So I want to say thank you to him. I want to say thank you to the philanthropies who stepped up to help fund our D.C. Education Equity Fund, because that is going to make a huge, huge difference for people in Washington, D.C. I also want to say thank you to the volunteers. We had a call last night with 1,800 medical professionals that called in to ask questions, and one person said on that call, I volunteered and I've been trained for the Medical Reserve Corps. When can I start? So I just want to say thank you to all the people of Washington. This is certainly a global pandemic of proportions that none of us could have predicted. But we will get through this, and we will get on the other side of this, and we will get back to life in our beautiful, thriving city. So with that, I want to turn to the chairman, Dr. Nesbitt, do you want to add anything at this stage, or we wait for questions? Okay. Thank you, Mr. Chairman.
Thank you, Mayor Bowser. And as you noted, Councilmember Gray, who's chair of the Health Committee, is also here. Many of the council members are participating online, although I believe there's some technical issues, and I don't know that they all have gotten the deck. And I'm just mentioning that because I've texted most of the members and asked if they have questions to convey them to me so that I can ask you. And I'm going to try to keep those questions related to the issue before us in this press conference,
Absolutely.
which is surge related. This is a concern that council members have raised. I appreciate that we've had these daily briefing calls with you or with your staff. And as you know, concerns about the surge have been conveyed or expressed by a number of council members. So we appreciate this briefing today. I mean, that really is the most critical public health issue, as I see it, is how we manage with the increase in infections, the increase that we know will be coming from the percentage that need hospitalization, and how are we going to handle that. So again, I appreciate your addressing that. Let me turn to Councilmember Gray if you have questions, and I'm going to be looking to see if any council members text me.
Oh, you go right ahead, Mr. Chairman. I'm delighted to be here. Mayor, I want to thank you very much for your leadership and that of your team in working with something that we've never ever seen in the history of the city. And you're absolutely right. We're going to get through this with flying colors.
Thank you.
I do not have any questions yet from members. So.
Okay. So I would like to ask Dr. Nesbitt to talk about a little bit more about the strategies to get to the additional beds. And if we could go back to the slide that shows the chart with the bed need. Yes, that chart. And if you would talk a little bit, and I think Chris Geltart, you may want to jump in a little bit because you have been working with the providers, the core, and our own internal teams about how we get to that capacity.
Sure. Thank you, Madam Mayor. As you all can observe from the chart, from the model itself, we have a need to identify capacity both for acute care hospitalizations and ICU beds. And we also do a calculation that looks at the number of ventilators that we will need in the District of Columbia. We look at it as it relates to the peak, but we also recognize that we will have a period of time as we are approaching our peak. The strategy is for us to be able to work with all of our healthcare partners in the District of Columbia to help them leverage the capacity or the infrastructure that is within the acute care system so that care can be provided in hospitals for patients who are the most severely ill and impacted by COVID-19, and then that any alternate care facilities that we establish would be for those individuals who require what we call post-acute care services, and for individuals, and then looking at our infrastructure for individuals who may have non-COVID-19 related illnesses who could be cared for in alternate care environments. So we've done some things like work with Children's National Health System, for example, because we are having some observations nationally and globally where the pediatric population may not be impacted as most or have severe illness that requires hospitalization. And so as the census or the need for hospitalization in a pediatric care environment decreases, how can the other hospitals in our healthcare system partner with Children's National to use them for inpatient admissions above what they traditionally admit, which is pediatric patients. So increasing their ability to admit patients up to ages 29, for example. So older individuals being able to be safely admitted into Children's National. So part of our strategy is looking at hospitals such as, George Washington University Hospital, for example, with 421 beds, that type of facility being used exclusively for ICU and ventilation capacity and more severe illness, and then alternate care facilities being used for post-acute care needs, such as individuals who are in more of a convalescent state, may require things like maybe IV hydration, but not as much of intensive care services. And so our model is built on working with the healthcare facilities to understand if they have any additional capacity within their healthcare facility, how could they use their operational space, such as typical observation units, recovery rooms outside of surgical suites, cafeteria space that could be converted, those types of spaces to get more beds within the hospital walls. And then any adjacent facilities around their properties that they have partnerships with to turn those into alternate care facilities. And that's how we increase the medical surge capacity in the district. So as the mayor has highlighted, we've already identified 3/4 of the additional capacity that we need, and we'll be able to deliver the first 1,000 of the beds that we have working with Mr. Geldart and the team, the Army Corps of Engineers, National Guard, those additional FEMA resources that we have to bring those first 1,000 beds online by April 15th. One of the things in the two models that the mayor mentioned that people often talk about is when will the surge hit? So will the surge occur in April? Will the surge occur in June? But we are also following what happens in the real world. So if the surge is actually lower and occurs in April, our planning assumptions allows us to be prepared for a lower surge happening in April and delivering those first 1,000 beds by that time. Do you want to add anything?
No, the only thing I think I would add to Dr. Nesbitt's assessment of that, which was right on, is we are watching what's happening in other cities and across the world so that we can best assess, not only, as Dr. Nesbitt said, how many beds we need when, but then also, as we're doing that, to ensure that we're constantly looking at the total amount that we need so that we can react and be prepared in our worst cases or in the actual cases. So we're really paying attention to this as we go. We're not going to let it get in front of us to all extent we can, but make sure we have what we need as we need it and stay ahead of as we're going up our curve.
And the last thing that I will add is that, again, referencing the mayor's opening comments, is that the models help us to plan for the future. We observe what happens in the real world, and our data scientists are able to make revisions to the model based on the things that we are observing in real time. So we can make adjustments to the model as we have more information about, as Chairman Mendelson mentioned, what proportion of our individuals are requiring hospitalization, how long people are staying in the hospital, how many days do people spend in the intensive care unit. As we have more and more information about what is happening in the district, we can make revisions to the model.
And I think what you see through that is a thoughtful process as we go through this, instead of standing up big, large aggregate centers right away with a whole lot of stuff and taking up a lot of necessary resources that not only us but our partners may need. We're taking a very thoughtful approach on this, getting the things we know we're going to need ordered and in, but doing it in a thoughtful way. Many of the questions are going to be around where will these sites be and all of that, and Dr. Nesbitt hit on a little of that. I'll just put out there that we've assessed over 39 facilities from across the District of Columbia, and that's everything from large facilities like this one that you're in right now, all the way down to smaller facilities like hotels and smaller spaces. So we've done a lot of research to see where we want to be when we need to do this.
Chris Rodriguez, do you want to talk a little bit more about the supply work we're doing?
Yeah, thank you, Madam Mayor. So in addition to what Dr. Nesbitt and Director Geldart were talking about, we have been very proactive in terms of not only requesting federal assistance from FEMA in terms of our supplies, whether they be masks, ventilators, and some of the other supplies you're looking at here on the screen, but also through other means and private manufacturers through our Office of Contract Procurement. So as we look towards medical surge, we're also looking to fill in some of the staffing and some of the supply needs that we know we're going to need that might not necessarily come from some of the hospitals themselves or from our traditional healthcare providers. So we're looking to also plus up in that respect.
Okay, and I can't emphasize how important that is. I was looking at one of our fellow Americans, Governor Cuomo, recently was talking about the federal support for some of these alternate care facilities that they've experienced in New York. And he made the comment, this is great, we appreciate the support with standing up these facilities, but we still need help with staffing and supplies. And the hospitals also emphasize that getting to the beds, getting to kind of the real estate is one aspect of it. But the bigger thing that our procurement teams are working on is how can we not only get to the supplies that you see listed there, but the people supplies, the people resources, the nurses and the doctors that we're really working hard to try to get those commitments to be in D.C. for the surge. Mr. Chairman.
Yes, thank you, Mayor. I have about a half dozen questions from council members, and I'm going to just ask them as I got them. The first is from Charles Allen. As we plan for surge capacity, what sites have we identified, such as the Armory? Should we find the need to add bed capacity for treatment and isolation?
Okay. As I mentioned earlier, we've assessed 39 sites. We're looking at a couple of different models for it. I will say in Councilmember Allen's area, Bridgepoint, who is in his area, and others also east of the river has stepped up for us in allowing space within their facilities to move patients within the system. And I know that the hospitals are talking about that now on how to move load around within the system right now so that we can have, as Dr. Nesbitt said earlier, the right care for the right people at the right places. So we're still assessing facilities. We know areas where we will like to go, but right now, as I said, we really want to be smart about where we're putting things and when we're putting them so that we're effective and that we're not using up resources that we don't need to too early on.
So there might be some concentration of COVID capacity at certain hospitals, for example. I think I'd heard the example of George Washington, whether that's in fact or just illustrative.
So one of the things that we know is that some hospitals, for example, were not operating at full capacity, and they had empty floors, for example, that had not been used in a couple of years. So our initial strategy is to be able to look at how they can bring those floors back online and create respiratory units on those floors. United Medical Center, for example, has been a tremendous partner in identifying ways to increase capacity in our system by reactivating floors in that facility and adding an additional 150 beds to our system just by looking at the underutilization of that facility. So they are able to identify brand new floors and additional beds that can serve as respiratory units, ICU capacity within that facility because the census in that facility has been low. So that's just one example. So it's not to illustrate just that GW has a lot of capacity in its hospital just by reimagining how to use the PACU and the observation unit and operating rooms as places of care, but we have hospitals in the district that have had a low census for a number of years that can now increase its ability to provide care to COVID patients.
And many of the assessments that we're doing is how do we help in that arena with helping them get those up rapidly and equipped and staffing, as the mayor mentioned, which is definitely is what's going to be needed across the board.
So I think what you heard, Chairman, is that a number of the hospitals, can I go back to the chart, have identified space within. Others have identified space close to their facility that could operate as a surge space. And we are still evaluating the need and the timing and the location if we had kind of a mass open facility, and which hospital would support that.
A mass open facility, meaning I'm going to call it a facility off-site from a hospital.
Yes, correct.
So part of the strategy is to have expanded capacity at or near, meaning on the grounds of, for example, a hospital.
Or close by.
So that their staffing, they can staff one geographic location as opposed to disparate sites.
Right, and let me say it another way. We are all that what we should think about this surge capacity is the surge from a hospital. Like folks are going to go to a hospital and how will that hospital accommodate their need for more space. And so that's how we have approached that, because these folks are in the hospital business and they know what they're doing and they know how to manage their surge. And so that's going to be very critical, because by that extension, they will be administering it, managing it, and we will be helping with the supplies and helping to find the staff that are needed for additional beds. So that is what largely you see here in making up the 75% of the beds that have been identified. And the last part of it is this mass care if needed.
Councilmember Trahan White asked, what is the process for someone who feels that they have contracted the virus to get tested at UMC?
Dr. Nesbitt?
Yes, so we have 2 ways that individuals can be tested. So the need for testing is still determined by a clinician. We have 2 options. So people can go to the site because they have been assessed by their clinician for the need for testing. So they've gone to their clinician either in person or they've had a telehealth visit, and their clinician has given them an order for testing. So they can, starting today, people can arrive at the site. The site is open from 10. Last person should arrive by 1:30 because the site is operational from 10 to 2. We now have a call line that people can call and schedule appointments. The site is open on Monday, Wednesday, and Friday from 10 to 2. They can schedule an appointment for efficiency. For people who are not connected to a healthcare provider and believe they have signs and symptoms, they can get that clinical assessment through our call line, our hotline. But we know that the majority of people in the district have a healthcare provider. Whether that healthcare provider is actually open and can do the swab is no longer of consequence, but they can do the clinical assessment over the phone and give them an order. And with that clinician's order, they can get an appointment to the site at UMC.
I have a question from Councilmember Mary Che. My question is, have we explored using dorms and hotels and, of course, the convention center and sports facilities for hospital beds?
Yes, sir. As I mentioned earlier, we've assessed 39 different facilities. Some of those are aggregate facilities, so we've been to just about every campus in the city and assessed dorms. We've assessed large facilities like this. We actually did assess the National Guard Armory, the convention center, and many hotels as well. So we're not limiting ourselves to anything in the city. We're looking at all different types of mechanisms. And some of the hospitals are choosing to use some of those mechanisms on their own. So as we are in the facilities business here, we're still narrowing that down to exactly what we believe the need is to meet our goal of getting our first 1,000 beds ready for when we believe we'll need them.
Thank you, and I appreciate I'm being a little repetitive, but I'm just forwarding these questions. Councilmember Silverman asked, how does our surge prediction compare with Maryland and Virginia, and are they using CHIME too?
Dr. Nesbitt?
So each state may opt to use their own state-developed model, partnering with their own universities and institutions. The state of Maryland used a hybrid model. They worked with folks at Hopkins, and they've used some different hybrid tools. We're still in conversations with the state of Virginia, who is finalizing their model.
And Councilmember Silverman also asked, if staffing is a major issue, won't we be competing with our neighbors?
So we're not only competing with our neighbors, we're competing with the entire nation who is looking for healthcare professionals. We've activated the Medical Reserve Corps, as the mayor mentioned. We've had over 3,500 individuals submit applications. A vast number of those individuals are healthcare professionals. We've also I've issued an administrative order on March 13th that allows for the waiver of certain licensure requirements that are specific to the District of Columbia, that allows health professionals who are licensed in other jurisdictions to come and aid in a public health emergency. So the processes are in place for the expeditious use of healthcare professionals. We've also done a call out to all of our health professionals, and will be able to assist any individual who is retired, whose license is in an inactive status in the District of Columbia, to allow them to become active again, to be able to work in the District of Columbia. So we recognize that every state may be having some staffing challenges, but we're working very diligently to be able to overcome them. One of the other things that the mayor mentioned in the conversations with the White House earlier this week is that the peaks will happen at different times in different parts of the country. And so we're being mindful as to how those human resources can be moved across the country to be able to assist. And so we're keeping our eyes on how to redeploy those human resources to the district at the appropriate time.
And I would just add to the end of that, Mr. Chairman, that we are, as we're planning the surge, in conversations with both Virginia and Maryland, if not a daily, every other day, about how we're all doing and what we're all working on, so that to the most we can, we try to avoid conflict within what we're trying to do. So, and really look at it as a regional approach.
Thank you. Councilmember Trayon White also asked regarding UMC, how many beds are allocated at UMC for COVID-19 patients, and how many new staff have been added to the hospital?
So if we go back to the model slide, I can kind of walk people through the process of how we look at current census versus the census that's unique to COVID-19. Just for the utilization of beds currently in all of our hospitals, we're sort of still in a calm state. So out of the 2,500 or so operating beds that we have in the district system overall, we're at a 65% occupancy rate of our overall hospital beds at this point. Typically at this time of year, we would be at 80% occupancy rate across all of our hospitals. So everybody's volume is down right now for non-COVID related patients. We are seeing it's continuing to see an increase on a daily basis of the number of patients who are in all district hospitals related to COVID-19. United Medical Center is not reporting on a daily basis that they are seeing an increase in COVID-related patients. At most, they may have 1 or 2 patients who are suspected of having COVID-19, and then those cases are coming back negative. So they do not have a high volume of COVID-19 related patients at this time. Our medical surge planning assumptions, as I mentioned, are that hospitals, acute care facilities would focus primarily on providing care to COVID-19 patients and have a small amount of their facility dedicated to COVID-19 care. Our planning assumptions in the model, in that graph, is such that 1,100 or so of the beds in our 2,500 system would be for non-COVID patients. And then the number above that would be dedicated to COVID-19. And that's how we make our medical surge predictions, based on that. And that's across the entire system. So UMC's planning is based on that overall assumption as well. They may get to a point where, as Chris Geldart mentioned, I'm always using their full names, two Chris's, using our planning assumptions is that when they have submitted their specific plans to us, they were very detailed in how they're working with other hospitals, in particular PIW and Bridgepoint, to be able to convert their facility, the majority use of their facility, to COVID-19 care.
This next question is from Brandon Todd. It covers some of what you've already spoke about, but I'm going to ask it anyway. How many beds at district hospitals are available for COVID-19 patients? And are we coordinating with private physicians to make space available?
Right. So our ability to use the private practice offices, the medical office building offices, is a bit restricted because of the types of the stresses it would provide on staffing, right? So if you go into a small medical office building that is used for daily private care or outpatient care, the configuration of those office buildings would require a different level of staffing for someone who is treated as an inpatient or someone who is spending the night in a hospital setting. We would partner with them in that we would ask them to redeploy their efforts to being staff who are available to work in our alternate care facilities. So reevaluating the need for their private practice to remain open on a 24/7 basis. Can they be providing services to their patients in a telehealth way and reduce the staffing in their private practice to become members of our response efforts for our medical surge needs?
Thank you. Councilmember Silverman had questions about several of the slides. If I'm reading this correctly, the chime model suggests April 17th surge. Help us understand the 2-month difference.
Right. So the IHME model is the one that suggests a peak in April.
Actually, that's what you wrote, and I
Yes.
thought that was a typo.
That's okay. That is the model that, as the mayor describes, that is the one that its limitation is that it overestimates the impact of the social distancing strategies. So when we talk about flattening the curve creates a long tail on your curve and shifts out when your peak will occur. So this assumes, and if you look at that model, which is available online, it assumes that every state in the country is going to have a peak in April, and then this will be over very quickly. That is not the impression that most data analysts have when they're developing the other models, or the impression that most state leaders are assuming will happen. So our model, the chime model that we have, and the data assumptions that we are using, and the real world experience that we are having here, predicts all the other variables to be very different in terms of the medical surge resources that we will need, the number of individuals who will be impacted in the district. One of the things that our model does show, that if with our planning assumptions and the number of beds that we are planning to bring online, we will still meet that 754 acute care beds that would be needed for April 16th. If that was our peak, we would still have that number of beds available. So whether you subscribe to the IHME model or the chime model, the district will be prepared.
Councilmember Silverman also asked, slide 8 is cumulative. What is our daily testing capacity now?
This is slide 8.
I think the operative part of the question is, what is our daily testing capacity now?
So we, at the Public Health Lab, we can test up to 300 individuals per day, and we will, at our max capacity, be able to test 500 individuals per day. However, we are not receiving nearly that many tests at this point.
Do we have sufficient?
We cannot speak to the testing capacity of the commercial labs, which individuals are still using, so that's additional testing capacity that is available. So physicians still send tests to Quest and LabCorp. And then a number of our hospitals have testing capacity within their own facilities. So they have the ability to run tests in their own facilities. So the overall testing capacity in the district far exceeds the number of tests that the Public Health Lab can run.
Do we have sufficient reagent at the Public Health Lab to do the capacity now?
Yes, the 300 tests per day, we can run that number of tests for a few weeks, and then they have reagents that are on order. We are, like every other state, still requesting access to more reagents. The instruments that they are using now are not dependent on resources just from the federal government, but we are ordering from the same places as other states.
Are we going to see the same kind of shortage competition with the other states with regard to the reagent? Reagent is the chemical that's necessary.
Correct. So there's the liquid that's needed to run the test. So I want to explain this in a much more comprehensive way, if you'll allow.
Yes.
So the strategies that the Public Health Lab used is that initially they were dependent on a reagent that was only offered by the CDC. So Dr. Smith and her team were very thoughtful in diversifying the number of instruments or pieces of equipment that they use to run tests, so we would have a minimum of 3 different instruments that could be used to run the COVID-19 test. They are actually even procuring even more instruments that could run, like the rapid tests that are being developed and approved by the FDA. When those come out, they make procurement requests to purchase those devices as well. The challenge that comes up is that there's an announcement made that there's this new rapid test that can run a test in 5 minutes, but it doesn't hit the market immediately, and then everybody stands in queue to purchase that piece of equipment. But right now they have at least 3 different instruments that can run tests, and we buy those reagents, we make the request for those reagents, and they have enough on hand to get us through the month of April.
At the capacity of, I think you said 500.
Yes.
And we're how worried are we whether we will get enough reagent for the month of May?
We've made our decision to operate the UMC testing site 3 days a week based on the capacity that the public health lab currently has.
Okay.
But what happens after April, I think is his
Oh,
question.
okay.
'Cause
So
we don't have-
we continue to order, and if those vendors then get into challenges, then we'll have to reassess where we are.
But at the moment, we don't see challenges, as you put it,
Correct.
with the order.
However, right, it depends on, this is the reason why we have to assess on a day-to-day basis, and why we keep in contact with the public and with you all.
Councilmember Silverman also asked slide 11, and I recognize the slides aren't numbered. Slide 11 looks different than other flattened curve models in press. Right side flattens. This is precipitous bell curve drop. Why the difference?
So we've asked our data scientists to make a prediction on what things would look like in the district for the duration of this pandemic. So I'm thankful for the question, because I do want to be able to talk about this in a way that we are looking at things for the district and the data sciences models that we are looking at in terms of what's actually happening in the district, as opposed to some of the models that are making predictions for every state. So we've been thoughtful about looking at what happens in every state. Right now, we are in mitigation. We are not in containment. We have widespread transmission. After you have the success of your strategies when you're in mitigation, you shift back into a phase where you may still have small clusters that start to happen again. You may have 1 or 2 people who still have infection and have the potential to cause small clusters. And you start to do the containment strategies that you were doing before, when we had 1 case, 3 cases, 6 cases, 10 cases. That's where your small tail happens again on the other side. So the curve, as the mayor mentioned, and this is a representation, if you notice, the 586 are the current number of cases we have, and then the curve, the bell-shaped curve, is demonstrating the total number of cases, so that represents everybody under the curve. So it is a statistical representation of everybody who we expect to be impacted throughout the entire year, and the total number of actual cases we have so far.
I'm going to ask another Councilmember Silverman question concerning slide 14. Suggests we will run out of ICU beds in 2 weeks. Am I reading this correctly?
And so April 13th?
Slide 14
Yes.
suggests we will run out of ICU beds in 2 weeks.
So
Am I reading this correctly?
around April 13th, April 15th, which is why we are delivering the first 1,000 beds April 15th.
So the surge
Yes.
will meet that.
Yes.
Councilmember Allen asked about grocery stores. No matter which model we use, one consistency is that the stay-at-home order will likely be in effect for some time. Grocery stores are essential but widely vary in steps that they are taking to protect their employees and customers. Should the mayor's order be amended to provide or direct grocery stores to consistent best practices?
I'll certainly look at that, council member. We recognize, and we've been in discussion with a number of the executives of these companies, as well as the labor representatives, about what the experience of what's happening. So I'm happy to look into the order to see if there's more that we can do with requirements for social distancing. I do want to make loud and clear that we said from the outset that grocery is essential, and it will not be subject to a stay-home order for people who work in groceries. But we do want to ask our residents to be very thoughtful about the number of trips that they take to the grocery and getting in and out with their essential food or supplies. So we continue to do that. But let me look at the order again.
Thank you. Councilmember Allen had another question. How does this model account for not just beds, but for impact to healthcare staffing? We can model our bed needs and surge capacity, but based on experience in other cities, we know we're going to see healthcare providers infected and unable to provide care. Certainly the Medical Reserve Corps hopes to help, but are staff impacts factored into this modeling, and how?
Sure, and thank you, Councilmember, for the question. As we look at our surge, the surge is really looked at in 3 factors as we're looking at it from the government to assist our hospitals who do the care of patients in this city. We look at that in facilities, supply, which also includes equipment and commodities, and the staffing. So all 3 of those go into, as we say, you see on the model here, beds. Those beds equate to all of those other factors as well. So as we're doing our planning for how we will surge, not only in alternate care facilities, but within the hospitals themselves, as we've asked them to do, as the mayor has asked, for them to do the 125%. We are having the discussions with them and working our procurement sides in every angle, both federal government and the private sector, to ensure that we're looking at all of those areas. What needs to be done in the facilities, the supply, and the staffing, all of it.
So just to kind of make that more practical, we know that we need folks. We have to pay them. We have to house them. We have to feed them. And we have to have a competitive compensation package to do that. And that is what we are aiming to do for our medical professionals. We know that medical professionals know the quality healthcare systems that we have here in the district. Many of them have trained here in the district and are very familiar with the district. And we're hopeful that they will look for an opportunity to come back to the district. And so that is the opportunity that our procurement teams will make available to medical staff around the country.
I know this was touched on earlier, but this is phrased a little differently. Councilmember Bonds asks, aside from hospitals, what are the specific sites identified for this surge?
So as we mentioned earlier, we're looking at all the different types of sites to help, not only with the hospitals making decisions on how to meet their 125%, but then also what we will need to do on top of that. So we've looked at all different types of facilities.
Another question from Councilmember Silverman. New York is having COVID-only facilities. Are we considering that?
Yes.
And she had another question. Yesterday, Washington Hospital Center said that syringes might be an issue. Are they, and what other supplies do we need?
Dr. Nesbitt or Chris Rodriguez, can you talk about the supplies that we know we need for the surge capacity? So it's been mentioned a couple of different ways that it's one thing to get to the real estate, to get to the beds, but that does not equal patient care. And so the people, of course, who will support patients, but all of the supplies that we think are needed, we can talk about.
So thank you, Mayor. So as you see here, these are the estimated supplies that we would need to properly and effectively staff some of our mass care sites or our surge sites. And we are in the process right now, and actually have been for several weeks, looking to procure these things, knowing early on that some of our models would move towards surge, and as we're seeing across the country. So we've been proactive, and even before we got to refine the model to the point that we're presenting today, we knew that we needed to try to procure these things. We're not near on some of these things where we need to be right now, but again, we are requesting federal assistance in some cases. We've worked with the National Guard on some of the staffing issues, and we will continue to do that. We do have a requisite supply right now of N95 masks. Our Office of Contract Procurement and the Assistant City Administrator have been very proactive in trying to look for N95 masks. So we are procuring those. Gloves as well, looking for large shipments of those coming in. And ventilators. We're also looking at how we can get ventilators, which of course a lot across the country are competing for. The other thing I want to get back to what Dr. Nesbitt said is, as we see other cities and other urban areas or states across the country begin to go down the curve, we are also preparing ourselves for a redistribution of supplies. And the mayor has had discussions, and I've had discussions with FEMA, because FEMA has a model that they are giving to the states to show need. And so we're, again, being very proactive at getting the data we will need to make sure that when those supplies are redistributed, that DC is at the forefront.
The other piece that I'll add is that in the organizational chart, Director Geldart oversees the operations unit, which has a health and medical branch. And I have staff in that health and medical branch who are the individuals who run the health regulation and licensing administration and oversee our healthcare facilities division. They have been working very closely with Director Geldart and his team and the team in the mission support unit that are working to identify what our global equipment and supplies needs will be for medical surge. That health regulation team that has vast years of experience with healthcare facilities have provided a compendium is probably the best way to describe it, of all of the types of supplies that are necessary to run a healthcare facility. So beyond the things that we are looking at as supplies that, or the PPE types of supplies that are necessary and the ventilators that are necessary for COVID specific related care, they have provided all of the types of supplies that are necessary for a healthcare facility, which are the things like IV tubing, IV bags, syringes, all of the things that are necessary to run a pharmacy, all of those types of supplies. That type of information has been provided for our procurement specialists that will match up with the medical surge needs for our alternate care facilities, and to help the hospitals who are still going to need to operate be able to plan for their medical surge needs.
So, Mr. Chairman, can we spend another 5 minutes or so on questions?
I think I have three
Okay.
more.
Oh, I'm
Greg
sorry.
has been trying to
If I could return to the retail issue that you alluded to, you talked about a bit about, Mayor, previously. I've been asked by the representatives of representatives of folks who work in our grocery stores, for example, given the fact that they encounter lots of people who may have been exposed themselves to COVID-19, why can't the people who work in these retail positions be provided with PPE to protect them from contracting the virus themselves?
I am certainly, I think in a perfect world, we would give the PPE to anybody who requested it. That would be our position. I think that we have laid out here what we see as the government first responder need, hospital, other medical providers need. I'm happy to have my team kind of model what it would look like to support other essential folks. I know that those businesses are also figuring out how they can get their hands on supply to take care of their employees, which we strongly encourage them to continue to do, and see if we added another level of essential employee for grocery, what that would look like for our supply chain, for our local, what we're calling it, the local
strategic supply.
Our local strategic supply. At this stage, I don't think we have what we need for the priorities we've already listed. Government first responders, medical professionals, this 5,000 beds for the surge. But we're working constantly to see how we can get more PPE in our supply. So can we take that to further model it and discuss it?
Absolutely, and I would love to work with you on that issue, especially since I think there's some real legitimacy to the questions that have been raised about why aren't we doing more to protect those who we are urging to be able to be available to people for their essential needs.
Absolutely.
Did you have anything else?
No.
I had two other council members had questions. One was from Councilmember Trayon White. If I understand this correctly, last night the Wall Street Journal reported that 1 out of 5 tests showed a positive reaction when in fact the person was negative. Can I guess it would be Dr.
you
Nesbitt,
familiar
can
with
you
that?
speak to that?
I'm not, yeah.
Can we take a look at the article and get back to the council member?
Sure. And then Councilmember Bonds had two questions, and I'll ask them both. Since we continue to have widespread transmission, what are next steps we can take to lower transmission given that the emergency is possibly lasting through June? And are we giving training to the medical corps volunteers so they might assist inside hospitals?
The answer to the first question is stay home. It's the best thing we can do to reduce transmission is to have people stay home and only leave your home for essential activities. That's the best thing everybody can do to reduce transmission. In terms of the training of the Medical Reserve Corps, we had a training last Saturday that was well attended and well received, and those individuals are receiving a myriad of trainings, including assisting with testing and to give the individuals the requisite things that they will need to be able to assist with various levels of our response. Licensed healthcare professionals who have experience working in healthcare settings will be deployed to assist with medical surge as appropriate. For individuals who have not worked in healthcare settings, we will be identifying how to best utilize them with our medical surge efforts. As outlined, medical surge will have a number of components to it: the acute care setting, the alternate care facility setting, and then there will be some logistic things that we will need support with. So we will assess every applicant for the Medical Reserve Corps for the appropriate task for them.
Thank you. And that's all the questions that I have. Councilmember Gray, did you have any other questions?
No, thank you.
Thank you, Mr. Chairman. And I know that you will plan to do your normal press briefing about the council's legislative session on Monday.
Yes.
And we'll return to the location outside of the Emergency Operations Center for your press briefing.
Okay. Yes, we're working out the details now. I'm looking at John. We're working out the details for how that will work. But the press conference that I have before a legislative meeting is the press conference we're talking about, and we're looking to do it jointly so that the typical press conference you're having can occur as well, and the press doesn't have to move to different locations. We are having a legislative meeting on Tuesday, where we're taking up a second emergency with regard to issues that have been identified since March 17th for us to provide legislative solutions.
Okay, thank you.
Thank you.
And so we will take one round of press questions. Paul, we're going to start with you and move down the line if you guys don't
Sure.
mind.
As people have been watching this, they've been tweeting at me and asking if now with the Chine projections on the surge, if you're not rethinking when you're going to possibly reopen schools, and B, if you are, do you have a date certain on when you may make that decision?
Of course, as I've always said, that we're going to look at the information on the ground to determine when we can get back to life in Washington, D.C. And opening the schools, to me, is the first sign of getting back to life. I don't think what we've seen with our modeling would suggest that we're going to open on April 27th. In fact, I can say we're not going to open on April 27th. And I will, after we've consulted with our public education team, we'll get back to you with a more firm date.
Two questions. The first, Michigan released racial breakdown on positive cases and deaths yesterday, and I'm wondering if that's something that DC is considering.
We will certainly work with our data scientists to get out as much information accurately and quickly as possible. This week we changed our reporting time, and I think that gave our teams more time for quality assurance and gave you some certainty around when we could release it. We also released it in a chart that I find more helpful: age groups, gender, ward of the residents, the home resident ward of positive cases as well. And we'll continue to work with our teams about how we get more data out.
And some council members are calling on you to declare grocery and pharmacy workers as first responders. I wonder if you're considering that.
I just answered Council Member Gray's question. He asked already about grocery workers. And so what we have, they are essential workers in accord with the mayor's order. I think the question is how would they fit into our local strategic supply for PPE? And we have to evaluate that. The data that we showed you demonstrates that we're procuring for all of our local first responder needs, medical needs, and we'll have to evaluate how we could add other essential workers.
Can we go back to the chart that has the estimated actual case projections, because we're getting a lot of questions from residents about that. So that chart shows 93,000 at July. To be clear, is the city saying that we're going to have 93,000 cumulative cases by July, or 93,000 cases through the length of this pandemic with a peak in July?
93,000 throughout the length of it. No estimation on the peak, when the peak number of cases will occur. You should only refer to the slide with the peak hospitalizations.
So that's showing peak hospitalization.
No, this is showing the estimated actual case projections with a total number of 93,676 occurring throughout the total outbreak in the District of Columbia.
And this chart, to be clear, goes through December?
Correct.
And the numbers that we see for projected cases, that's overall infections, not just the confirmed cases
that is
through
correct.
testing?
That is correct.
The other question that I have is just following up on Paul's earlier question. Under what circumstances could we see social distancing measures released before July?
Dr. Nesbitt?
So in addition to the modeling data that we have presented today, we look at other trends, including whether or not we're seeing a decrease in the rate of transmission, and whether we are seeing any change in the number of days to doubling of cases. Those are other metrics that we look at.
Mayor, I have a question. I get a number of emails from different areas of the government, forensics lab talking about social distancing, DPW parking talking about social distancing, the jail talking about people who have been quarantined, but their roommate is not quarantined. Is there anybody in the government, I know you're telling the public to, stay at home or social distance. Is there anybody monitoring social distancing inside the government?
Yes, absolutely. And so let me step back a little bit, Sam, because we are telling the public to stay home, and we have very definitely characterized workers in D.C. government as essential. Well, more than half of our employees are doing their jobs at home. And another very critical group has to report to their workplace. They include our firefighters, our police, correctional officers, DPW workers who are still collecting on all of their routes every single day as expected. We also have our human services workers who are processing benefits and manning our shelters. We have our unemployment staff. We have executive staff who are still working on the budgets, who are still working on reimbursements, who are crunching data, who are issuing reports, who are responding to press inquiries. So we have a lot of people in D.C. government who are doing the essential work that allows me to have the information and recommendations to respond to this pandemic. And we all have a role to play. We are privileged to be public servants. And we're called on right now to respond to a global health pandemic. So each of the directors is getting information, and they have the Department of Health to go to for guidance. And we're following the Department of Health's protocols, which is informed by the science and the CDC about workplace changes or congregate setting changes when a person is identified as positive. So if there continue to be questions, we'll make sure from the Department of Health that we're getting those workplaces the information that they need. And when we have been presented with a problem, or if there hasn't been enough room, for example, for social distancing, we've made those changes.
That's what I'm saying. I know the rules are in place, but is anybody enforcing them? For example, a person at Forensics said they're concerned that if they complain, that there'll be retribution. So the question is there anybody actually enforcing these distancing rules?
Well, if there's a problem, we have to know about it. And so while I appreciate you asking me about it, that employee should really use their chain to say, listen, we have a problem, Deputy Mayor. I don't have enough room here. I need more space for social distancing. And that we will make any changes that need to be made. Mark?
Yes, so one quick question, or several questions, but quickly first. Are you going to issue an order or recommendation that all DC residents begin wearing masks? You talked yesterday candidly about not wearing gloves. You were seeing other leaders around the country talking about telling residents to wear masks regardless of whether they're symptomatic.
I will, and I'm sure that DOH is evaluating what's coming out of the CDC, and when DOH has a recommendation, if necessary, we'll change it. Our recommendation is that you stay at home.
And then can I ask about procurement? You talked about procurement. Yesterday we heard from the White House, both from Jared Kushner, who I'm sure you probably saw, who said the national stockpile is for the feds, not for the states, and that the president tweeted out that governors and mayors were overestimating or exaggerating the needs of medical equipment. Could you respond to that, or given the numbers that you're putting out that are behind you that you need in relation to what we're hearing out of the White House?
This is no exaggeration. And I think that I didn't actually hear Kushner's remarks. And our understanding of the national stockpile as evidence of them making distributions from the national stockpile, not just in this instance, but in other disasters, is that the stockpile is there to assist in emergencies. I think what the big difference is this is a nationwide emergency, and I don't know that stockpile has been tested. Disasters typically happen in one state, a few states at a time, but we're talking about 50 states in the District of Columbia that are simultaneously impacted. So I think the truth is that the stockpile hasn't been tested in this way when you have had a disaster. This is a public health emergency, but a disaster in every part of the United States of America. And so that would be my comment. You heard from Dr. Nesbitt already how we arrived at this model. We think it is, and we pray, I'm just going to tell you, we pray it's wrong. We do. But we're looking at all of the modeling, and we don't think one that says we don't need any additional beds is a model that would be safe preparation for the residents of the District of Columbia. And we think that model is what the White House has relied on, first to say that we could open up by Easter, and then later we could open up by the end of April. So the CHIME model that's in front of you, we think represents what we're seeing on the ground in the district, our healthcare system, and our city. And that's what we base our need on. Now, wouldn't it be, and this is what we highlight, and I can't comment on what other states are exaggerating. I know a lot of the people involved in all of these decisions, and I wouldn't say that they're prone to exaggeration. But I do know the things that we need. We are the nation's capital, and for the first time that I am ever aware of, the nation's capital is not being treated as a state for federal funding. And it would be a crime not to make sure that the capital of this nation did not have the supplies that it needs. Now, this has been my communication to the White House, to FEMA directly, that not only are we talking about Washington, D.C., but the 6 million people that make up this capital region and cross borders for work. cross borders for hospitalization, cross borders to visit family and friends. This region also, of course, is the seat of our federal government, has a predominance of very critical federal facilities, and these are not exaggerated needs. This is what we need to keep our people safe.
Mayor, Allie texted us from WAMU. She had a question about can the mayor or her staff confirm or deny whether she and or members of the administration have been discussing the possible reinstatement of a control board, and how likely is it economically or politically that a control board can be appointed?
I can deny that. That is not true. And we are very, very mindful of our finances. We are working with our chief financial officer, the city administrator, my budget office, on what we will need to do for the upcoming budget. We will present a balanced budget to the council, and the council will pass a balanced budget. Will it be the same budget that we had intended just a few weeks ago? No, it won't be. Because we have been hit very hard with declining revenues. We expect the CFO to confirm what those declining revenues are, and we will have to make changes. The things that we hope that we would be able to do with this budget were transformational for our city, I have to tell you. But we will have to rework all of that to deal with the current revenues based on this pandemic. But we will have a balanced budget.
And then Allie's second question is, can we start to see cuts to housing funds or other social services?
Allie, we will have a different ability to invest in the things that we want for our city. We will be prepared to have a discussion about that once the new revenues are confirmed. I will begin working with all of my staff, my cabinet, to look at their agencies as well. And we will. This is a conversation for another day, but it is a day coming soon.
And then Martin from WAMU, can you tell us why, again, DC is using CHIME estimate instead of IM estimate? Are we just preparing for the worst, but nothing could happen in the end?
Dr. Nesbitt?
So we assessed a couple of models and made a decision that given the behavior, the elements of human behavior, that the CHIME model was more appropriate for us. And even within the context of the CHIME model, we looked at a number of different scenarios that would give us the different types of situations that could happen in the district as it related to the impact of social distancing. In that situation, we felt that a model that determined that the district would have essentially no medical surge needs was not indicative of what we anticipated would be our reality in the district, and felt that a model that did not overestimate the impact of social distancing in the United States, and that other states that had looked at the IHME model who were further ahead, for example, like New York and New Jersey, and we're seeing their actual need for medical surge beds, ICU beds, need for ventilators be in conflict with the IHME model, that the CHIME model would be more appropriate for the district.
And then Sophie from the Washington Times asks, if the peak isn't until July, what will life look like in the district, and will businesses continue to be closed? And then her other question is, with a seventh of the city's population projected to be infected, how will that impact the function of government, healthcare, and first responders?
So I'll take the first question first. Everyone does not have the infection at the same time, and individuals can become convalescent or recover from their illness and then return back to function. And so if there are essential workers, they can return to work. Not every essential worker would be impacted at the same time, essentially requiring the city to come to a halt or putting a strain on all of our healthcare resources, which is why the model, as it relates to medical surge, shows the estimates that it shows. We look at factors other than the model for medical surge, which is what was presented here today, to make recommendations to the mayor as it relates to our social distancing measures. And those are things that I have discussed already related to the rates of transmission, our days to doubling of the number of new cases, and some other factors.
Okay, we have time for more quick round. I'll go, maybe I'll start in this order this time. And if I could ask you to be quick. Mark.
So Mayor Bowser, just, and you touched on it a little bit, but people are going to hear these numbers, are hearing these numbers, and it's startling. What do you say to people who are hearing these projections, hearing the length, the duration, that now this is going to go into summertime, before life gets back to normal? What do you say to residents who are, quite frankly, just freaking out right now?
Well, we promise to tell you what we know, and what we know that will be that will make the experience in the district better. And that's what we're here to tell you. We're using the best modeling. We've input all of the data and everything that we know about our city, our residents, our hospital system, and this is what is being spit out. Our residents also know, because they're watching every day, the experience of other cities, the impact on those hospital settings, the impact on those healthcare professionals, and we want them to know that we have a little bit more time to get ready than what we've seen in New York, and we're working every day, all day and night, to make sure that we get ready. So if these models are true and we have this level of infection in our city, that people will have the healthcare resources that they need. I have to also emphasize the point that Dr. Nesbitt just made. While that chart shows people who will be affected over the course of a year, it is less well shows the people who have recovered and who will have had this experience, who will have recovered and gotten back to life. And people should also know that we still have a lot more work to do to understand what restrictions will have to be in place for how long in order to get back to normal. And that we shouldn't think of it as one day we have 100% social distancing and the next day we're wide open, because I think a lot of the professionals now are thinking through ways that life could shortly get back to normal, but not all at once. So that's what I would tell people. So let's focus on the things that we can control. You can control your movements, watching your systems, watching your symptoms, contacting your providers, checking on people in your life, especially people who are living alone, and making sure that people are okay. Also remembering that the physical symptoms are certainly one aspect of this crisis, but a lot of people are feeling stress, economic stress, lost jobs, and mental health concerns. So we want to check on people throughout our city and just be there for one another. Sam?
Yes, ma'am. There is a nurse practitioner. Her name was Joelle Gelman. She resigned from DYRS yesterday. She knew Kenneth Moore. She said that the reason she was resigning was a lack of PPEs, inadequate support, and fear for the kids. What do you say about workers who are in your government and who have basic concerns like this?
Well, I don't want to talk about any one employee, Sam. Certainly, I'm sure she's representative of a lot of people who serve an essential job. And we have worked very hard at DYRS. For people who don't know what you're referring to, one of our employees who had been out, I think since March 18th, in self-quarantine, during the period of his self-quarantine, developed symptoms, later test positive, and he died from COVID-19. He was 52 years old, and he was a 13-year veteran of DYRS. So we're certainly very concerned for his family. We also know that he hadn't been since his period of self-quarantine at the facility and in those days between his death and March the 18th. And my team also informed us of part of our supply. You may have seen in this slide on the supply distribution showed that masks and gloves were delivered to DYRS, DOC, and other of our first responders in the last couple of days.
Okay, but she resigned yesterday. But the other thing, inadequate support, fear for the kids.
We, of course, are fearful for all of our residents, especially those who are in our care. And we have been very focused on our vulnerable populations in the city. We have a pretty low population at DYRS right now because of a lot of hard work of a lot of our public safety agencies. And Director Clinton Lacey is attempting to move as many of the kids. I think they probably had less than 20 kids there to another facility where they could have single rooms and single bathrooms. So we're getting the population at New Beginnings down as low as we can. And that will also mean that fewer staff will need to be there because there are fewer kids who are there. Bennett.
Can you explain to DC residents why you're using a model that suggests that social distancing won't be enough to get to push the peak past April, and why even with social distancing we might have our peak in hospitalizations in July?
So I think you've heard, and I'll turn to Dr. Nesbitt. Dr. Bree, is it? Who is at the White House? Burks. Dr. Burks. Dr. Burks has frequently made this statement. If we do everything perfectly, this is what we can expect. My experience with human beings is that we don't do everything perfectly. And our model accounts for people who are very strictly social distancing, and theirs I think is accounting for a 2-week or 30-day period, and for all the variations that we will experience with social distancing. So this model is, I would call it not the rosiest that you've heard in other places, but more realistic to our experience.
Yeah, I would state that it's inaccurate to say that we are using a model that suggests social distancing does not work. Our model takes into account an impact of social distancing, and it does not overestimate the impact of social distancing from most data scientists and epidemiologists' perspective in a way that IHME does. So every model has its limitations, right? So this model is believed to overestimate and as the mayor stated in her opening remarks, she gave the limitations of the model that we are using. It is believed to overestimate the amount of contact that individuals will have with each other. So those are the types of things that you have to be familiar with when you're looking at the various models. There are models that Johns Hopkins has developed. There are models that a number of consulting firms have developed, and each model is going to have a different limitation. They're going to include a number of different variables, and being familiar with what each model does to give a different result is extremely important.
Yes.
Mayor, what would you say to workers who've so far been excluded from unemployment benefits and other assistance because they don't have an SSN or proof of income? And should these workers get assistance comparable to unemployment benefits?
Give me that question again.
Sure. What would you say to workers who have been excluded from unemployment benefits because they don't have an SSN or proof of income? I'm thinking of day laborers, street vendors. And do you think these folks should get something comparable to unemployment benefits?
Well, I would certainly say my heart breaks for everybody who is concerned about health and wellness, but also concerned about the economic devastation that this pandemic has visited upon us. And I think that from a federal response to a local response, we are looking for every way to help DC residents and every way to help DC businesses and our local government get back on its feet. And so I think that we will continue to look for ways to help. I have to say, however, that this is not the type of response that can be handled locally only. and we have to be very mindful of that. That the needs that we have from individuals in the district and our businesses in the district is going to require a national response. We cannot meet the need for every individual and every business with only district funds. Yes.
I want to follow up on Councilmember Gray's question about these frontline retail and grocery workers. I think it was a trial balloon that may have been launched by some of these grocery workers worried about their health and PPEs. If you go into some of these establishments, you see they're already doing that. They're wearing masks, they're wearing gloves. There's plexiglass now at Costco and plexiglass at Starbucks. The companies are doing what they can for these employees. If you were to, I think you said, change your order to allow these people to be considered frontline first responders, if you will, would the city then be offering to supply PPEs to these people?
I think I've answered this question twice, but here, what I told Councilmember Gray and Councilmember Allen before that was that we would evaluate how they could go into our local strategic stockpile. If you recall the chart that shows our distribution, we are still procuring PPE for our first responders, for our medical workers. I just described to you the need to create these 3,600 new units with supplies as well. My commitment to Councilmember Gray was to have our team of modelers see if another group of essential personnel, non-government essential personnel, could be fit onto that list and how we could help prioritize that. So I want to thank you guys for your cooperation. I know that our press family has also suffered some losses. Patrick at Fox 5, I want to send my condolences to him. I just talked to him last week, and he reported out to the community that he lost his dad to COVID-19. And my friend Shamari Stone, whose family I got to meet while I was in Michigan a couple of years ago, by happenstance at an event. I know he lost his grandmom, so we want to send our condolences to them as well. Stay home, everybody.